and do that trick we all learned from teaching and learning with the presenter view. Thank goodness for that. So tonight we're going to be talking about counseling and ethics, and I'm pretty excited about it. I know that sounds bizarre. Let's go ahead and take a moment to do a grounding activity. Last week or the week before, I alluded to something called the relaxation response, which has been found to reduce heart rate, reduce blood pressure, reduce our breathing rate, reduce oxygen consumption, and upregulate our parasympathetic nervous system. So all great things for us, sometimes for our students or clients. So what I'd like to try, and this is a breathing focus, in order to elicit the relaxation response, we really just need two things. We need to focus on slowing our breathing and focusing on just one thing. So what I'd like us to try together, and I recognize that our paces will be different, so don't feel like you have to follow along with my breathing pattern. But what I'd like to try is to do 2 brief sniffs and then a resisted exhale, whether that means that we are pursing our lips and breathing out very slowly as if we're flickering a candle flame in front of us, or using a shh or a s, or even the letter F to resist that exhale so that we're making the exhale much, much longer than our inhale. So let's give it a try. We'll do this for maybe a minute or two, and then we'll launch in. Please continue. I'm going to let Irene know what we're doing. Irene, we are practicing 2 quick sniffs and a long resisted exhale, either through pursed lips or with a s or with a sh. And we're going to continue for about another 30 seconds. All right, let's take a pause. So I'm going to ask you to give me a thumbs up if you feel like the emoji you check right now is different than the first one after that little grounding activity, and a thumb to the side if it would be the same. So, okay, about half and half. All right, super. So this is the kind of thing that we can do even while we're just driving, or um, while we're in a meeting, or even just, before we go to bed at night, or on our way into work in the morning. So let's launch into talking about ethics. Before we do that, if you're interested in playing around with some controlled, relaxed breathing, there are 2 nice apps. I have no financial relationship with either of these. The Breathing Zone for iPhone, it has a really nice little icon, kind of a graphic that changes shape and size as you breathe, so you can kind of follow it. Gives you something to focus on. And the Breathe app for Android by Jatra is great for Android, and that's the one that I use. And I like it because I can set the number of seconds for my inhale. I can insert a certain number of seconds pause at the top of my inhale, and then I can set the number of seconds for an exhale and a pause at the end of the exhale. So I can really tailor it to what it is I'm wanting to do in the moment. Um, Courtney says, I can tell you're a voice specialist. So, little secret, this breathing strategy that we just did is something that we use for people with paradoxical vocal cord movement disorder, because when we breathe in with a sniff, it opens our vocal folds nice and wide. And when we resist our exhale, it also keeps our throat and our vocal folds wide open. So, check out the apps if that feels helpful. So over the next 2 weeks, and please do shoot me something in the chat if you have a question, or just call out. One more discussion post, and you're done for this course. So as per usual, initial post please by Friday evening, and then any required responses by Sunday evening. Knowing that, just to review, then the updated expectation is that you will provide a total of 6 responses over the course of the class. So if you've already provided 6 responses, you're done, unless somebody's post just moves you to contribute in some way. Um, if you decided to do one post this past week, then you likely have one more. So just keep track of how many responses you've done. If you're unsure and you've lost track, you can always reach out to me, because it's my job to keep track of all that stuff anyway. So let's just kind of round out the discussions this week, put that to bed, and then we can look forward to the communal responses, which are kind of a crowd shared sort of resource for both interesting information you found out about trauma-informed care, if you've done some looking, and I hope you will. And that can be a blog post or a webinar or a podcast. I love podcasts. It can be an article, peer-reviewed, doesn't need to be, tutorial. I know within the K-12 literature, there's a lot more trauma-informed teaching information. And so academia is a little later in adopting that. So for you folks that work primarily in the schools, you may find more about trauma-informed teaching than your colleagues in academia. So please just share 2 interesting resources about trauma-informed care that you've identified. And then for the other one, I'm going to ask you to just upload or just write down 2 helpful scripts that you've used to either explain something or summarize or provide validation or affirmation for a patient or student, or the way you sketch out therapy. So for instance, if you've already looked, you'll see that I've included just a sentence stem. I think I may have used, so it sounds like you, blank, 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 and then I explained why I like it. So I'm going to ask you to give a little script and explain why it's useful briefly. Doesn't need to be long. And then do 2 of those. So they don't have to be long at all. The other one I did is kind of my meta therapy explanation of voice therapy and what voice therapy is all about. So think about what you use and please share, because I think, I don't think of myself as an expert in this setting, because we all bring so much to the table. So this is just an opportunity to share what you bring with others. And then we have the counseling approach application in the field project. And this is really choosing, researching, and developing some type of educational content for educating your peers on a counseling approach that you've already chosen. And you can choose this as something that you would use to educate your work peers. This is why I think this is really important. Here's how I use it. Here's how it jives with trauma-informed care. Here are the micro skills I might use with this approach. And then think about, what mechanism might be most helpful. Would an educational poster be helpful? Would, a brief PowerPoint presentation or a video, something that you can create to push out information that you feel really is important and valuable. You can even think about, if you're not thinking about your peers in your work setting, you could think about your peers in this class. You could think about providing, a brief presentation at a regional or state conference. Now, this is not an hour. It's not that, but, a broad sketch of, say, no more than 10 minutes, maybe more than 5, but no more than 10 minutes of a presentation of, here's why I want to sell you on the benefit of this counseling approach for this setting. Or you can think about it as being something even broader, something that you might want to share in video format at the national level. Here's what I've learned, and here's why it's really important. Here's why it jives with trauma-informed care. And here are some of the counseling micro skills that I might use. Here's a couple of, suggestions or ideas or scenarios, and why it feels important to you. Let this be really what you feel is going to be most salient for the audience that you choose. I'm not vested in any particular form. It'll be really fun and interesting to see what you choose. And I think that, thinking about your audience will help guide you toward the particular type of presentation that you decide, whether it's verbal, written, poster, article, little like bloggy article, that kind of thing. So, any questions about this before we head on? Okay, I'll stick around afterward. I know y'all have class, but I'm always available. You can reach out, have a meeting, whatever you need. So let's talk a little bit about where we're going this evening. We're going to talk about scope of practice. We're going to tether scope of practice to counseling in professional service delivery and the ASHA Code of Ethics and how these jive together. And then I want to share with you an excerpt from the SIG 20, which is the counseling SIG, an excerpt from their most recent webinar that specifically addressed scope of practice and a mandate for counseling in our profession. And then if there's time, I'm going to invite you to go to some breakout rooms and talk about how you might share. How do I determine whether this is something that I'm addressing or whether this is something that I can't address as a speech pathologist, and how I might communicate that with my school age student, with a parent, with a master's student in academia. So let's get to it. So SLPs engage in the following activities to counsel people with communication and swallowing needs in their families. They they empower the individual and family to make informed decisions related to communication or feeding or swallowing issues. They educate the individual, family, and community members about communication and swallowing disorders. They provide support or peer-to-peer groups for individuals with disorders or challenges and their families. They provide those individuals and families with skills that enable them to become their own self-advocates. They discuss, evaluate, and address negative emotions and thoughts related to communication or feeding and swallowing disorders, as well as referring individuals to other professionals when the counseling need falls outside of those related to communication or feeding and swallowing. So this gives us a really clear scope, that we are not providing mental health therapy globally, but we're providing counseling moments, events, and responses to assist with empowering, educating, supporting, developing self-advocacy, and addressing negative emotions. So it's broad, but it also starts to provide some guardrails for us. According to the ASHA practice portal specific to counseling for professional service delivery, the goals of counseling are basically enhancement of client and family or caregiver understanding of, acceptance of, and adjustment to their condition, increased engagement in management of the communication or feeding or swallowing challenge, increased autonomy, self-direction, and responsibility for acquiring and utilizing new skills and strategies that are related to the client goals, enhanced both physical and psychosocial well-being and quality of life, improved understanding of how to modify contextual factors to reduce barriers, enhance participation, facilitate successful communication, and manage related disorders. Enhance, now ASHA says enhance compliance with treatment recommendations. I hate that word. So I would prefer to say enhance adherence to recommendations and enhance benefit and satisfaction with treatment. So counseling can address and be useful for describing evaluation procedures, diagnoses and eval results, problems experienced that are secondary to communication or swallowing conditions, the effects of the challenge on psychosocial or behavioral adjustment, including interpersonal relationships, social activities, and occupational options and performance, effective or emotional reactions to the communication or feeding or swallowing challenges, development of coping mechanisms, problem-solving skills, compensatory behaviors, and systems for emotional support, development of and coordination of individual or family self-help and support groups as well. So it's a lot. And we think about, as we go through graduate school, and I know that some of us are many, many, many years past graduate school, and I'm really talking about me, not any of you. The focus was really on the big 9 areas of speech pathology, and not so much with, counseling was, well, I didn't get any counseling in my graduate program, but I was definitely schooled in how to relate informational counseling, but dealing with these other things was just really not part of it. And there are many things that counseling can address. Now, there are also several statements within the Code of Ethics which can relate to counseling, including using every resource, including referral and interprofessional collaboration, to ensure that quality service is provided so we don't have to go it alone. Making sure that we are operating within both our scope of professional practice and our scope of competence based on our certification status, our education and training, and our experience, and that we'll work collaboratively with other members of our profession or others. So that's that interprofessional collaboration in order to deliver the highest quality of care. So between the scope of practice and the counseling for professional service delivery and the Code of Ethics, we have some guardrails and some direction of how to make choices about how we counsel, when we counsel, and whether we counsel. Now, if we're feeling like, hmm, I'm really not certain that I'm competent to jump into that role, I think that we definitely will tend to avoid those things with which we're uncomfortable. And you know, you are all enhancing your scope of competence because you had a desire to take this course and learn more about it. Even though I can tell you after reading all your posts that you're already doing amazing things in the realm of counseling. I'm really actually in awe of all of you, and it's been so fun to see your posts. But we can build our scope of competence through CE offerings, coursework like this, or specific coursework in different treatment modalities, and independent learning, picking up a book, reading some tutorials. So while we don't have to be certified in a therapy approach to utilize helpful aspects of a therapy approach, we should definitely feel like we have adequate skills before stepping into any specific counseling modality. So, and that kind of begs the question, why should we step into this role at all? We've talked about this, or I've covered it in terms of our scope of practice and ethics, et cetera. Um, but we all understand, and I can tell that you all do, that we can't separate a communication or a swallowing challenge from the individual or the family member experiencing it, nor can we separate the expected emotional response from that person regarding that challenge. Plus, as communication specialists, we're uniquely qualified to address the emotional responses to communication and swallowing challenges that are experienced by those people that we serve. Even more crucially, um, there are not enough mental health therapists, either accepting insurance or not, to serve the mental health needs of all those that have a need in our community at this point. And so that has really driven a push in the UK to develop something called stepped mental health care. And so it's a global sort of approach to mental health care. And people, speech pathologists have also used this concept of step care to attempt to meet the mental health needs of individuals post CVA through a stepped system of intervention. So let's look at the graphic and we'll see it again on the webinar video. So level one refers to services that all professionals can provide and that are provided to all clients. Now keep in mind this is post CVA. So including information and education about mental health challenges post CVA and active monitoring for those mental health challenges. Now, as we look up to level two, and you can see they're using a scale, which is called the Hospital Anxiety and Depression Scale. I don't know that any of you are familiar with it. I am not. But they're using this scale to determine some of the different levels and what services are needed at each of these levels. So to address the needs of level two, the National Health Service in the UK has trained over 6,000 psychological well-being practitioners. It's a new work title to address the increased mental health needs in people post CVA that are meeting a certain criterion on this scale. I believe that the Mental Health First Aid Organization provides education that may be quite similar to what is provided by the psychological well-being practitioners in the UK. I've taken the mental health first aid training and it is excellent and I highly recommend it. It gives very practical information about how to recognize a mental health challenge and a mental health crisis of different types and how to respond as a layperson when we see this. So this is not for mental health counselors. This is for people like you and me. So above level 2, at both levels 3 and 4, the needs are deemed to be beyond the scope of a well-being practitioner. And it's at this point that a dedicated mental health practitioner would provide the needed service. So this is where a mental health counselor or psychologist or psychiatrist would then be providing direct treatment for people struggling with these issues. So I think that we can think about using stepped care as a guide as well. We can develop certain skills to assist those we serve, but and we may develop knowledge of one or several different mental health counseling modalities and use them effectively within the lane of scope of practice ethics and counseling for professional service delivery. But there will still always, or not always, but there still may be issues that we feel are both beyond our scope of practice and beyond our scope of competence. If there's time later, I'll tell you a mildly amusing story about my bumping up against my scope of competence that happened several years ago. But for now, what I'd like to do is take a quick break from the slide deck and stop sharing and shift over to the SIG 20 webinar so that we can have a look at that. Now, I want to apologize in advance. This webinar was hosted by SIG 20. The person that had the slide deck didn't advance the slide deck. So you're going to see the slide deck just stay very static. And the person speaking is going to be in a box up to in one side of the screen. I think it's big enough for you all to see, but it's not as slick as some of the other things that we may have seen in the past. So let me go ahead and share sound and optimize for video and share it with you, and then sit back and we'll all take it in together. Be ready to change your audio if it seems too loud for you. Okay, here we go. And we're going to watch a little over 20 minutes of this.
I want to reiterate and emphasize everything that everyone has discussed to this point. And I want to take one step back. I know that Rebecca Crowell was going to be here tonight and isn't able to be here. One of the things that she was going to mention is this idea of a mandate for counseling in our disciplines. And I want to talk about where that originates. Part of that originates in the framework that ASHA has set up. Counseling is one of the 8 pillars of our clinical practice, and wellness and education are 2 of the other pillars of clinical practice for speech language pathologists and audiologists. So that to me is a mandate. It means that it's something that we have to do, and we have to incorporate, as Chris said, in every moment of our interactions to be effective in doing our job. To establish that therapeutic alliance means that we are affectively connected to individuals, like Tony said, but we're on the same page as well. We share the same goals as them, so we've done some work to figure out what those goals are, and we share the same context or vehicle for therapy through the activities that we choose, because they're chosen collaboratively with those individuals. And to go along with what Chris said earlier, we, sorry, train of thought just kind of passed me for a second there. We acknowledge their competence. We show through our words and actions that we believe that they have a stake in their own therapy, their own interactions, and they should get those choices, regardless of whether they're 2 years old or 93 years old. That's a fundamental human right. So to kind of step back and talk about that mandate, this is one of our roles, and we should feel bold and confident in taking that role. As I saw Larry Bowles said in the chat, there's been some really good conversations in the chat, and I kind of want to dig into those as they relate to the idea of what happens when things do reach the border of our scope of practice, and when should we refer and what should that referral look like? So I want to dig into that just a little bit more. Ian Kneebone didn't necessarily invent this model, but has really brought the stepped care model into prominence, particularly in acquired neurogenic disorders. But I think it has broad application across our discipline. The stepped care model, and I don't know, Chris, am I able, or Ying Chao, am I able to share screen? Is that possible?
Yeah, I can stop and you can share here.
Yeah, let's stop for just a second. And I'm going to put the step care model in front of people because I think fundamentally this helps to provide some clear guidance to us. Maybe it's better when it's not full screen, actually. I don't know if you can see everything, but it provides some nice guidance for us in terms of what is our scope of practice, what is the scope of practice of a psychotherapist, and when do we share areas of scope of practice as well. So in this model, level 1 is something that all speech language pathologists and audiologists should be equipped to do from their general training in terms of their academic training and clinical training. So that includes some really simple things that we do every single day. And in fact, we as a discipline are the experts on those things. Those should be fully in your wheelhouse, whether you've had specific counseling training or not. So there's a few things that fall into some areas where you might need a little bit more specific training, but the idea of group problem solving, group relaxation therapy, leisure and increasing participation through activities, those are things that we're equipped to do right off the start. Level 2 can be in the domain of a speech language pathologist or audiologist if they've had additional training. So I know there was a conversation about cognitive behavioral therapy, and if we start doing that, if we're trained to do that and we start doing that with a client, is that dipping into psychotherapy? From the perspective of the psychotherapists who write about this model, their perspective is that there are more needs out there than they can possibly address as a discipline. And if they have individuals from other disciplines, related disciplines that have skills in this area, they should definitely step into that level 2 domain to deliver those kinds of interventions. That's a part of their role. If you're not trained and if you don't feel qualified to do it, you shouldn't step into those next level interventions. But as a base level, everyone should be comfortable at level 1. When we start getting into level 3 and level 4, those are areas that are clearly related to a bigger, deeper need for psychotherapy. But that doesn't necessarily mean that we stop working with those individuals. So that's a point when we make a referral and we say, the needs of this individual are beyond me. And for some of you, that might happen at level 2. And that's a really squishy gray line, as Tony said earlier. But when we get to level 3 and beyond, those are a level of needs that we're not equipped, we're not trained to be able to respond to, nor do we have the time to do that along with everything else we need to do as a speech language pathologist or audiologist. That doesn't mean, and I always say this, it doesn't mean that it's a handoff, right? Like, oh, you've got level 2 needs, I'm not ready to handle that. You've got level 3, 4 needs, I can no longer talk to you. Those people are still your clients, they're still your patients, right? So you have a responsibility to provide supports related to communication, even to those individuals with additional needs. It also means that part of our role may be to work with the psychotherapist that we're referring to gain the skills to support communication and other cognitive needs that they're not equipped, they're not trained to do. So part of our role is to say, okay, so you're going to interact with someone with severe aphasia who has these significant needs. You need to know how to interact with someone with aphasia. And oh, by the way, that's our expertise as speech language pathologists. So I'm going to help you with that process. And as I help you with that process, you may help me to know, to have a little bit of a better idea of what my steps are from a counseling standpoint within my scope of practice. So I think a model like this sets up a framework that guides clinicians, that establishes a level where clinicians who have additional training can operate, but a level where all clinicians can operate as well. And I think that level one really aligns well with what Chris was talking about in terms of counseling being infused into every moment of our clinical interactions. It's not all written here, but it's the empathetic listening. It's the reflections and the affirmations and the prompting of problem solving and identifying potential solutions. That's what those level one kinds of interventions foster. It's not providing answers, telling people what to do, having the solutions. And I think when SLPs and audiologists start to recognize that, as Tony said, it takes a lot of pressure off of things. You don't have to have the right thing to say. You need to listen. You need to be able to prompt this person's own opinion about what the best next steps are. And those other things will kind of fall into place. I'm going to stop sharing and return to our conversation.
Gary, can I just piggyback off something you just mentioned about, you were talking about the CBT practitioners asking for help, right? That they can't work with everybody, right? I also think sometimes we have a maybe grand idea of what these counseling techniques are, right? You don't have to have a degree in psychology to help somebody challenge a thought process, right? You don't have to have a degree in psychology to ask somebody a certain type of question, right? We're not prescribing medicine, right? We're speaking, we're communicating, we're asking questions in a certain way. And these techniques are nothing more than a way of communicating with our clients, right? And we're all perfectly capable of learning them and practicing them. These aren't out of our reach.
Yeah, thanks, Chris. I'd like to jump in there as well, because I think one of the things that we need to remember is we tend to think of ourselves, we think of ourselves as speech pathologists or audiologists, and it's like that seems to narrow the scope that we have to actually work with people into this behavioral dimension. And I think what we have to realize is if we're an audiologist or a speech pathologist, we're working with people. We're not just working with a larynx or an ear. And when we work with people, there's not just one way that one approach that we use to help them. So the behavioral work that we do is in itself a form of psychotherapy. It's a form of counseling. It's just behavioral counseling that addresses one aspect of the person that you're working with, but there are other aspects of the person that need addressing as well. And we draw from, just as we draw from behaviorism to build our repertoire of things that we do in our behavioral counseling, we can draw from other traditions to to work with the other aspects of our clients that really need our work as well. So if you're thinking about it as working with a whole person, you draw from different discipline or different traditions to work with those different aspects of the client, rather than just thinking that we only do behavioral stuff. And so I think we need to kind of remember that just because behavioral is one thing that we do, it's not the only thing that we do.
Yeah, just want to piggyback on that. I think maybe this is a time we need to talk about in terms of counseling in the context of speech language pathologies in various, all different disorders. There's, what circumstance that the client may need a counseling, other than, we kind of overall recognize, yes, we are working with the whole person, but each disorders have some kind of clientele have some kind of particular issue, not just one, could be, some one or two, or, something like that, how we can, better to help with them. So Chris, you want to take on that in the context of this?
I thought Rebecca asked a really good question, like a really pertinent question in the chat. It's how much training is needed to use these prompts or techniques? Do we need a certification, or can we execute a professional development program of reading books, taking continuing education credits, going to a talk at ASHA, etc. And so what I immediately think of is, let's take for example, acceptance and commitment therapies focus on values, right? That we help our clients identify what they value and then make choices and decisions that are in line with those values. Let's say I read a book about ACT and I go to a talk at ASHA about ACT, and I think, that's an idea that makes sense in terms of my practice. Then do I then go into my therapy conversations and not ask my clients about values because I don't even think you can get a certification in some of these things. You can certainly get a psychotherapy degree or something, but like, if you have an idea and it's a good idea, you shouldn't not use the idea just because you don't feel qualified, right? If it makes sense to you to ask a question, say in this example about client values, then go ahead and ask the question, right? There's no it's not crossing any ethical boundaries.
Chris, can I build on that? One of my favorite articles about counseling in clinical practice is by Simmons Mackey and D'Amico in 2011. And in that article, they talk a lot about this idea that when we're uncomfortable with something, we avoid addressing those moments. And I think that's a big issue. Your level of confidence relates to the level that you should be practicing at. So certainly the level of preparation that you have. But if, like you said, Chris, you know what to do, you're ready to step into that moment, then by no means are you crossing the lines of scope of practice in that moment. You've got the skills to address the moment, whatever, however that levels out in terms of skills, that's fine. That's a totally appropriate thing to do. I think what people fear is that they don't have the right answer, as Tony and Chris both alluded to with students. I don't have the right answer, so I don't want to step into that moment and say the wrong thing or do the wrong thing or send the person down the wrong path. You don't have to have any answers. All you need to be able to do is to draw out that person's own ideas, to draw out their own perspectives, to get them to think about things and ask those kind of questions. That's our role. And if you feel comfortable doing that, then you should feel like you're in your communication scope of practice, as long as it relates to the other everyday work that you're doing. So
Can I say something that might be controversial, but I don't think it is? Jerry's talking about working at your comfort level. Sometimes I think we have to take a risk, right? That certain ways of asking questions, certain techniques or interactions are always going to be uncomfortable until we do them. Right. And so there might be something that you read about in a counseling book, and it seems like far out, right? It will always seem far out until you just do it. And it might go terribly. That's okay, right? You're not a surgeon, right? Like you can mess up and you can say, huh, I won't do that again in that way, but maybe next time I try it, I'll do this a little bit differently. And then you try it again, and eventually you get better at it, and then it's a part of your practice, right? I think the word practice is actually imperative here, that you get good at something through practicing, right? You can't just keep reading and reading and reading. You have to actually take a risk.
So agree, Chris. I'm a big proponent of finding your counseling voice, and finding your counseling voice implies practicing that, right? Saying it and saying, oh, well, that sounded really artificial or really stilted or whatever. And you have to try out different voices. I've stolen parts of all of my mentors and colleagues to kind of fulfill my counseling voice, and I do it with no apologies to those individuals. I've stolen really great things from people who are in this room, and that's just such a valuable tool. But you do it wrong first many of the times, and it doesn't end the world. One of the other favorite techniques that I have, and it relates to what Chris said about doing things outside of your comfort zone. You know, none of us, well, maybe someone in this room feels comfortable having conversations about sexuality or about end of life kind of decisions and things like that, but those are uncomfortable conversations. And one of the models that's predominantly used in those situations is begins with this idea of asking permission, or excuse me, not asking permission, giving permission to talk about this. That one puts you on the hot seat for the future, right? Like if you say, you know what, I'm happy to have the conversation about intimacy with you and your partner. I'm happy to have the conversation about end of life decisions, right? We don't have to talk about it right now. But if you're ready to do that at any point, I'm happy to have that conversation. Inside, I might be thinking, holy crap, why did I just say that? But later on, it really helps, because when they bring it up and they say, Jerry, you said you would have this conversation. No, they brought it up. So I don't have to have any trepidation over, is this a conversation they want to have? They already said, I want to have this conversation. And when you're on the hook like that, you learn, as Chris said, and it's just a really valuable tool. It doesn't allow you to avoid things that you desperately want to avoid, perhaps.
And the last thing I'll add on to that is sometimes the discomfort is in not saying something. So a lot of counseling for us is resisting saying something, even in awkward moments of silence. But the hallmark of really good counseling is that the client is the one that's doing most of the talking. We don't have to say a whole lot, and sometimes that puts people into an uncomfortable, it stretches their comfort zone, to actually not say something or feel like they don't have to come up with, again, that right thing to say or the profound thing to say, and they just are reflecting, encouraging the client to continue to talk, to build their story. Those moments of silence are really powerful because it really often forces the clients to dig deeper. And so that resisting saying something is often just as much part of that kind of stepping out of your comfort zone.
Let's stop there. And just take a quick, just seeing if there's any reason to continue with the slide deck. Not really. I think we're good. So these have been two really content heavy evenings, and I haven't left a whole lot of time for breakout rooms, and I'm so sorry for that. My plan for the next 2 weeks is to have much more time for breakout rooms and discussions than we've had thus far. I just really felt like that webinar would be helpful to see, especially as we're talking about scope of practice. So any thoughts about what you've seen? Any
I have thoughts.
personal? Yes, you have thoughts.
I
Great.
have thoughts. Okay. I happen to know some of those guys. And so there's a couple, like, I agree, you know, I understand, I see the pyramid and I understand level 2, but some of the things that Chris brought up was this, you know, this idea of taking risks and making mistakes in counseling, which I don't know that I agree with that. I think that you have to be really careful. I think that we can risk, you know, pushing somebody into something that they're not ready to talk about. And then there's another guy said something about, like, if the client brings up something like end of life decisions or said sex or something, I'm uncomfortable with that because I feel like that's definitely going outside of our scope of practice. So I'm just curious about your thoughts on that, and if anybody else agreed or disagreed with them.
I'll jump in real quick if that's okay. I think especially in the end of life discussions, when I was in the hospital, I was involved with those discussions quite frequently because there are people who indicated in their living wills that they didn't want to have any sort of alternative means of nutrition, but they had severe dysphagia. What are their options? What do we do now? And so outlining for them, here are the different options, and encountering all sorts of things. I had one person say, so they're either going to starve to death or they're going to choke to death. And, kind of brutally, I guess that is what I'm saying. But no, I definitely think that that's our place when it relates to something like dysphagia.
I think in your example, it's appropriate because, for example, one of the things that you probably have had to do is try to educate the families on, like, what does that mean? We're not going to provide nutrition. Does that really mean they're starving to death and suffering, or does that mean the body is doing what it does naturally? And so, if in your case, you might be helping to educate them and explain it to them so that they don't have to feel like they're torturing their loved ones by starving them. It's just not really what's happening. I think that makes a sense. That's more appropriate. Yeah, I can see that. I worry about some of the things that Chris was saying, though, about the not being too afraid to make mistakes or
Taking risks.
the things that he was saying to people when what if they're not really ready for that, or being a little bit more mindful of whether or not a person is ready to hear something or pushing that. I know Chris happens to be a stuttering person like me, so I've heard a lot of his perspective, and that to me just seems a little uncomfortable.
I can certainly speak to the idea that there's one thing for us to take a risk and to make a mistake, and is that trauma informed if what we're saying or the manner we're saying it in ends up being re-traumatizing for the person that we're talking to.
I think that's kind of how I'm feeling.
Yeah. And so, my thoughts are, and again, not the expert, you all have your own thoughts. And part of this course is for you to further hone your own beliefs and values and ideas around counseling. But I think if I'm going to take a risk, I need to know that person pretty well. And I would rather be maybe practicing with a friendly peer or a family member or someone that I can easily repair with, as opposed to someone that I have a therapeutic relationship with, that if I make a mistake, am I going to lose that person to follow up? So those are some of the things that I think about that. And I think your concerns are well founded. I'm hoping that, and it's so interesting you bring this up, and I know we got 2 minutes left. When we get into week 5 and challenging conversations, 2 of those sections are about intimacy conversations and end of life conversations. So I'll be really interested to hear what you all think about the different sections and how to, when to, if to have a conversation about a challenging topic. Any other quick thoughts before we go? And I do promise more breakout rooms are coming. There's just a lot of stuff to get in. I'm so sorry.
I have a question. I'm sorry.
Go ahead.
Mine's just fast. It's more about like if we're gonna cover this, but one thing that I feel like this kind of comes up a lot for like I work in a school, and a lot of times parents will like start like once you kind of start like at like open a conversation to talk about things, and they start like really unpack like unzipping themselves and telling like a lot of stuff. And a lot of times, especially in like schools, we have like only like the 45-minute period to go over this meeting, and we have to get back to classes and stuff. And then it becomes like too long, and then we don't end up talking about like what the meeting was called for. And I feel like sometimes they don't even like scrape the surface enough, because I don't want to like, for time purposes, I don't want to like even get into stuff. But obviously that's not
Yeah.
like good counseling. So I was wondering if there's like tactics to use to like have a meaningful conversation, but also keep it like brief and like on topic.
Why don't we throw that in next week?
Okay.
Sound good?
That's my biggest barrier. Like, I mean, I like to like poke the bear sometimes.
Counseling's about poking the bear, especially in terms of our comfort level. So I'm gonna let any of you go that need to go. If you want to have a quick chat afterwards, I'm going to stay here. So thank you so much for listening, and enjoy this week of content. And I'll see you next Tuesday. Sorry, I'm so confused about what day it is.
I had a quick question.
Yeah, hi.
When I fill in the Google Docs, I noticed there's also an assignment link that we have to submit for the assignment. Should we be also submitting our responses in the assignments?
You know what I have done in the past about that, Alyssa, because that's a really good point, is if you wanted to just when you get the submission link, send a tiny video and say, "Hi, Carol, I completed the Google Doc," and that will take care of your submission.
Okay, I could type that in too, right? Do I have to send you a video?
You can probably type it in. No, you don't have to send me a video. It was just a helpful hack that I had last
Right, I have class, so I
semester.
won't cut you off. I'm already late.
Bye.
But okay, so fine. You'll look at the Google Doc. Thank you.
Yeah.